Hi everyone, welcome to week 5. This week we'll be covering the effects of exercise on cardiovascular disease, continuing the focus from last week where we discussed the pathophysiology of cardiovascular disease. Be epidemiology of exercise in terms of how it affects cardiovascular disease risk. We'll be considering studies that look at the actual benefits to the heart itself, cardiac benefits, and also to the benefits of the arteries and blood vessels. And then lastly, we'll finish by talking about various risk factors for cardiovascular disease, such as lipids and blood pressure, and how these factors are improved by exercise. Let's start by examining this meta-analysis that examined whether there is a dose response between physical activity and magnitude of risk reduction for coronary heart disease. Essentially, they're wondering, is more better in terms of more exercise, more benefit? And just as a reminder, a meta-analysis really is the highest level of evidence when we're assessing a question in science, because they're quantifying the data from many different studies together. So looking at not the results of just one study, but statistically examining the composite of numerous studies. The way this was set up was comparing the amount of physical activity that people were getting based upon the federal guidelines. So it's recommended that people engage in 150 minutes per week at moderate intensity, just as a minimum for basic health enhancement, or for further benefits, 300 minutes per week at the same moderate intensity. Alternatively, people can engage in 75 minutes per week at vigorous intensity exercise, which is equivalent to at least 6 or greater METs. And then for further health enhancements, 150 minutes per week of vigorous intensity. Now, not everybody engages only in moderate or only in vigorous intensity. So alternatively, if energy expenditure would be the caloric equivalent of either of these, for women that turns out to be 500 calories per week at minimum, or 1,000 calories per week for more advanced benefits. Also for men, 600 calories per week at a minimum, or 1,200 calories per week for more advanced benefits. So looking to see at these different levels of exercise, are there further reductions in risk of developing coronary heart disease? All right, here are some of the results. Just to start off with, the way that relative risk works, if you have a relative risk of 1.0, in this case for engaging in exercise or being sedentary, that would indicate that there is no change in risk for coronary heart disease between being active or sedentary. Looking at the y-axis, as relative risk here decreases from 1 and goes down to 0.8, that would indicate a 20% reduced risk. If you go down to 0.4, that would be a 60% reduced risk, and so forth. Conversely, if a relative risk was above 1, that would indicate increased risk. Now, looking on the x-axis, this is looking at the category of leisure time physical activity, with the small number being less activity and the larger numbers being more activity. So what we can see is that generally the lines are decreasing down to the right, indicating that the relative risk of developing coronary heart disease decreases as physical activity increases. Each of those black circles represents data from one study, and the larger the circle, the larger the study. So collectively, this is indicating a protective effect of engaging in leisure time physical activity, generally showing that more physical activity provides greater protection. This slide is presenting the data in terms of calorie expenditure, and we can see that, again, looking at the y-axis, which is depicting our relative risk, if you go over to about 2750, we can see definitively that there is about 20% reduction in terms of heart disease risk, and that's because if it's close to 0.8 for relative risk, that would indicate a 20% reduction in risk of the condition. And really, as little as about 1,100 calories of exercise energy expenditure confers close to the same benefit there, still about 20% risk reduction. These graphs depict the pooled relative risk for coronary heart disease reduction by gender. So in our top left figure, this is looking at the risk reduction based upon calorie expenditure from exercise for men. The dark line would be the average relative risk, so the reduction in risk. And then the lighter lines above and below represent the 95% confidence interval. So you can see that above rather higher expenditure does confer a tiny bit of a protective risk, but not that much more, whereas for the women in our below right column, there is a more pronounced protective effect at higher levels of energy expenditure. So you can trace the relative risk from 0.8 to 0.72 all the way down to 0.52, so a 50% reduction in risk at 2,500 calories from exercise energy expenditure. This study, were that on average, looking at males and females combined, meeting the minimum recommendations for physical activity leads to a 14% reduction in heart disease risk. Meeting advanced recommendations confers a 20% reduction in heart disease risk, but there even might be benefit below the minimum recommendations. So when you're talking with people about something is better than nothing, that's certainly still true. And the relationship between increased physical activity and increased benefit and protection was more pronounced among women. Now, a different study published in the Wislov paper, I have the reference provided for you here. They were discussing a study that their group conducted that included a 16-year follow-up period. And their data indicate that doing one single bout of high-intensity exercise each week reduced the risk of cardiovascular death by 39% in men and 51% in women. And interestingly, they didn't find any additional benefit from increasing the duration of the exercise. And their conclusions were that intensity is really the key factor in conferring protection rather than duration. Wislov's paper also described some of the actual physiological adaptations that occur from exercising. For example, a study led by Cox and colleagues looked at 7 weeks of intense endurance exercise, so either cycling or running 6 days a week at 85 to 90% of VO2 max. And this led to positive adaptations in the left ventricle for participants who were previously sedentary. And Wislov's group did a HIIT intervention for intervals at 90 to 95% of heart rate max. And in addition to increasing VO2 max, this also led to a 12% increase in the left ventricular mass and an increase in contractility by 13%. So the heart was getting bigger and stronger, and that study was in untrained females. Another paper by Wislov's group that you should have read for this week, published in 2007, this was the first to look at high-intensity interval training among patients with heart failure. So they started with a very low ejection fraction. You can see here 29%. And previously, this population really hadn't been encouraged to engage in high-intensity training due to concerns about adverse cardiac events that could potentially happen. However, this study compared moderate intensity continuous training, MCT, with what we call HIIT now, but AIT stands for aerobic interval training. And VO2 max increased in both groups. It increased a lot more in the group engaging in HIIT, and ejection fraction increased a lot in the group engaging in HIIT. So this was the first to indicate that high-intensity interval training is certainly appropriate for patients with heart failure. Further mechanisms that may be leading to the improvements in the patients with heart failure here. Our top figure is looking at the rate of sarcoplasmic reticulum calcium uptake. And we can see that between the control group as well as the moderate intensity group, there were no significant changes in the rate of calcium uptake. However, there was a significant increase in the rate of calcium uptake among the group engaging in high intensity training or aerobic interval training. So this is showing that the sarcoplasmic reticulum is taking the calcium up faster, which allows the heart to relax better, which allows it to fill with blood again. So overall, we call that improved calcium handling. And this is directly linked with the improvements in contractility as well. Below that, BNP stands for the brain-derived natriuretic peptide, and this is a marker of heart failure. So this is good for it to decrease, and we can see that the only significant decrease among conditions occurred in the high-intensity training group. All right, this study came out of Arizona State University, and it was comparing conventional training, which is continuous moderate intensity training, with high intensity interval training among patients with heart failure who still had a preserved ejection fraction. So their ejection fraction had not yet decreased. The scale upon which people were compared is a 3-point grading scale where higher numbers indicate worse function. So the patients who did HIIT training here, they improved their score from a mean of 2 to a score of 1 on this grading scale. And this is really a huge improvement for heart function and another indicator that high-intensity interval training may be appropriate for patients with heart failure. Other mechanisms by which exercise improves heart function. The maximal shortening velocity increases by 60% in cardiac muscle cells that have been isolated. These data are coming from Wislov's lab again. They do a lot of work with rats where they remove the rat's heart and they can isolate the cardiac cells. And so from those types of experiments, they're able to get really precise mechanisms. So exercise leads to an improvement in terms of the shortening velocity, so better contraction here. It also leads to better handling of calcium, like we talked about before. So calcium gets released faster from the sarcoplasmic reticulum, which also increases contractility. Calcium is also reabsorbed faster, so there's more time for filling of the heart for the next contraction. So faster calcium release, also faster calcium reabsorption. And this increased calcium sensitivity is experienced by troponin as well, and that allows for more actin and myosin interaction, which is another mechanism by which we get greater contractility. This figure from the same paper it's showing an actual cardiomyocyte here, so a heart muscle cell. And want to break down this figure here. If you look on the y-axis on the left, we're looking at size of the cell. And the arrow is showing that with training going up to the right, the size of the cardiomyocyte would get larger. And then when someone stops exercising, it would get smaller from detraining. And then we can see the y-axis on the right side is looking at contractility. And again, as training increases, contractility of the heart increases as well. With detraining, there is less contractility. And then our little insert figure here is looking at VO2 max. And this is again indicating increased contractility with higher intensity exercise. Another effect of exercise is that we actually get hypertrophy of the cardiac cells themselves. And don't get too hung up on memorizing the specific proteins in the figure here. The general concept that we want you to get is that exercise leads to an increase in protein synthesis in the cardiac muscle. What the figure is showing is the molecular mechanisms by which it appears that this is happening. Also, from the text of this paper, it was shown that 2 months of high-intensity interval training led to about a 14% increase in the size of the cardiac cells. Moderate intensity training led to an increase as well, but not nearly as much, just about a 5% increase. Now, to wrap up the portion of the lecture looking at heart adaptations, exercise leads to an increase in cardiac contractility by 3 primary mechanisms. It leads to an improvement in calcium handling, it leads to hypertrophy of the cardiac cells, and it increases calcium sensitivity. Exercise, another big mechanism by which the heart is affected. Exercise leads to greater stroke volume. And 2 primary ways that this happens would be due to increased contractility, so a more powerful contraction. Also by increased filling of the heart, and this is because of the ability to relax more, so longer diastole, to be able to fill up the ventricle. And this is due to an improved calcium handling. So 2 big effects, an increase in contractility, greater stroke volume, and then more specific mechanisms by which those outcomes happen. All of these adaptations happen both with moderate and higher intensity activity, but the changes are more pronounced with higher intensity activity. Now we're going to turn to the vascular benefits of exercise. Last time we talked a bit about endothelial function and also dysfunction. So the way that endothelial function is improved by exercise, multifaceted, but involves the following. There's an increase in flow-mediated dilation. Really, this just reflects the improved vascular health. It's a marker of vascular health. But some of the reasons that this is improving is because of an increase in nitric oxide release, which is due to increases in the enzyme endothelial nitric oxide synthase. So we're producing more nitric oxide, which is leading to an increase in dilation. There's also less cell adhesion molecules, and so they're not sticking to the endothelium as much. Therefore, there is less inflammation and less of the cell adhesion molecules are being called in response to the perceived inflammation. This leads to a decrease in oxidative stress. And the last point, looking at LDL, there's less LDL produced due to exercise. Of the LDL that's present, less of it becomes oxidized, and so there is less oxidized LDL available for macrophages to engulf and to become foam cells, which would be an adverse effect and be one of the steps in the progression of atherosclerosis. This figure is coming from the paper by Green and colleagues, which you were supposed to read for this week, and it depicts the two types of adaptations in the artery in response to exercise training. First, we see functional adaptations, which occur as soon as 1 to 2 weeks after beginning exercise, and this is reflected in the flow-mediated dilation test. So we're seeing an improved ability for the artery to dilate in response to the pressure from the blood flowing over it from that shear stress. The other type of adaptation is a structural adaptation where the diameter of the artery actually increases. Since these both are occurring, the increase in the artery diameter, by nature, there will be less pressure than less shear stress at a given blood volume because there's a greater diameter and volume over which that blood would be covering. So if you look at the functional adaptation arrow, you'll see an initial improvement, and then it looks like the arrow decreases. But this is because at that same time, we're having the positive structural adaptations. So there's simply less need to vasodilate as much when there's a larger artery diameter to begin with. In terms of the data about both of these types of adaptations, there's more robust literature pertaining to the functional adaptations that we see through FMD testing. So both likely contribute to the benefits of exercise training, but the ability to vasodilate is particularly key, that functional adaptation. Exercise training for a period of weeks. And the way this study worked, all of the subjects in the study had coronary heart disease and they were awaiting coronary bypass surgery. The novel thing about this study is that vasodilation was assessed both in vivo, so actually inside the person, as well as in vitro by removing part of their artery and examining vasodilation essentially in a petri dish here. So half of the group, they engaged in substantial exercise, an hour a day, 7 days a week for 4 weeks, and the control group did no exercise. The way that they were looking at vasodilation, essentially it's this very similar to flow-mediated dilation where they're looking at a nitric oxide dependent vasodilation, but this was stimulated by infusing acetylcholine into the artery for the in vivo portion. And then for the part of the artery that had been removed and was being examined in the petri dish, that part was also exposed to acetylcholine in vitro. From the study indicated in vitro, we could see that there was an increase in vasodilation that was directly related to an increase in the amount of the enzyme eNOS. This is the enzyme that makes nitric oxide, which is what leads to vasodilation. And then also looking in vivo, so the assessment when we were looking at the vasodilation in the person, we saw nitric oxide dependent vasodilation increase. And that's very similar to what you assess with flow-mediated dilation. But in this study, they were looking specifically just inside the artery. Conducted a follow-up study where they compared the effect of either inserting a stent, which is a very common treatment for coronary artery disease, or having a group do exercise, and this was a 1-year follow-up. I've included a picture of what it looks like to have a stent put in place here. So essentially it opens up the artery to allow for better blood flow. In this study, the exercise group had a lower rate of cardiovascular events than the stent group did. And this is a good thing. So cardiovascular events would be outcomes like heart attacks and stroke. And bottom line conclusions from this would be stents are expensive. So this is an invasive surgery that costs thousands and thousands of dollars. Exercise obviously is not. And so to be more cost effective, in addition to being more effective in terms of health outcomes, exercise is superior. Other paper you had to read for this week was by Six et al.'s group, with the reference at the bottom there. And they were comparing the effect of 6 months of exercise versus a sedentary control among patients with coronary artery disease. The way they conducted their assessments were measuring actual coronary blood flow by having a small ultrasound actually inserted in and looking at vasodilation that was stimulated by inserting acetylcholine. So again, acetylcholine stimulates vasodilation, and they were looking at how vasodilation at rest and in response to the acetylcholine. They did this before exercise training and after exercise training. Bottom line is that coronary blood flow doubled after training, so a huge improvement. And we'll look at the figures on the next slide. From that study, let's look at the figures on the left first. In our top figure, panel A, it's showing the effects for change in diameter with the intervention group, so the exercise group, and then below we have for the control group. And this is looking at the changes in artery diameter when exposed to acetylcholine. And you'll notice initially here, some of the participants at baseline actually had low levels, which indicates they were vasoconstricting, not vasodilating. And that's kind of common in patients with coronary heart disease, even though that's not what you would be wanting or expecting. Following 6 months of exercise, however, you can see virtually every line sloped up to the right, indicating an improvement in vasodilation, whereas no such changes were really happening for the control group. Pretty stable lines, flat or even trending down. Over on the right side, figure 2, looking at changes in coronary blood flow. So the one is the diameter, the other is the blood flow. And again, increasing significantly, like 100% on average for the intervention, the exercise group, and then not much of a change for the control group as we would expect. Studies earlier talking about the heart, so now looking at the effect of HIIT versus continuous training on vascular function. And the next study we'll talk about here actually was Dr. Sawyer's dissertation study done at Arizona State University, where for 8 weeks, 3 days a week, participants were exercising on the bike in the lab. They were doing, if they were in the HIIT group, it was 10 1-minute intervals at 90 to 95% of the participants' heart rate max, with 1 minute of recovery between each of the intervals. The continuous intervention, for comparison, did 30 minutes of activity at 75% of heart rate max. The average BMI was about 36, and so all participants needed to be obese in here by body mass index definition, and everybody was sedentary to begin with. The participant in the picture here, his baseline weight was 350 pounds with a BMI of 50, and he was in our HIIT group. At the end of the study, 9 people were in each group, so 9 people per group completed the whole study. All right, so results. Primary outcomes of interest were flow-mediated dilation. And what we can see here, the green line shows the increase in flow-mediated dilation that occurred among the HIIT group, going from on average 4.8% to 8.6%. And again, this was just in 8 weeks. So a significant increase there. The continuous group, the blue line looks like it's decreasing, but that was a non-significant decrease. However, there was a significant time by group interaction, indicating that there was a difference in the way that the groups were changing over time. In addition to FMD, the group also looked at brachial artery diameter and changes over time. Now, it might look like the HIT group had a larger baseline diameter to begin with, but those are really wide 95% confidence intervals, and so that was not a significant difference at baseline. Also, you can see the HIT group remained relatively unchanged over the course of the intervention, whereas the continuous group experienced a significant increase in diameter of the artery. And so what this would be representing would be not the functional improvement, which was experienced by the HIT group by increasing their FMD. Rather, the continuous group here is showing a structural adaptation because the actual size of the artery increased. So two different types of adaptations were manifested between the continuous and the HIT group. The HIT group had an increase in FMD. The continuous group had an increase in brachial artery diameter. Looking at the baseline artery diameter. Now this one is looking at the peak diameter, which would again be representing the ability to vasodilate. And here, just like with the flow-mediated dilation, we see that the HIT group had an increase in brachial artery peak diameter, whereas there was no significant change among the continuous group. So this further backs up that the HIT group had changes in the ability to vasodilate, whereas the continuous group had the structural adaptations with a larger baseline artery diameter. Now to recap, talking about what we've seen in terms of vascular improvements in response to exercise. Really, the driving factor behind the improvements would be the shear stress on the artery walls. So we're going to have increased shear stress during exercise. That's the stimulus for these adaptations. The studies that we've discussed thus far in the PowerPoint provide direct evidence that we have improvements in the ability to produce nitric oxide, which is largely due to increased levels of endothelial nitric oxide synthase, the enzyme that stimulates production of nitric oxide. There's an improved ability to vasodilate, and we've also seen evidence of artery remodeling, which means that the artery diameter actually gets bigger. There are also coronary blood vessel improvements, and this is really critical because we're seeing it's not just the blood vessels in the skeletal muscles, the peripheral blood vessels, but we're seeing improvements right at the level of the heart and brachial artery improvements as well. Of factors listed below, and having metabolic syndrome really increases the risk of developing type 2 diabetes and of cardiovascular disease. So to be diagnosed with having metabolic syndrome, somebody must have at least 3 of the 5 criteria. Central obesity, so that's what the apple shape there in the figure is referring to. Technically, that'd be defined as an elevated waist circumference above 35 inches for women and above 40 inches for men. Be having high blood pressure, high triglycerides, low levels of high-density lipoprotein cholesterol, or insulin resistance, which is typically defined as elevated fasting blood glucose. And the more of the risk factors that you have, the greater the chance for developing type 2 diabetes and cardiovascular disease. Meta-analysis from 2013 depicts exactly some of the specific outcomes from exercise on components of metabolic syndrome. And Table 3 summarizes this nicely. Let's look at the mean effect. Low-density lipoprotein cholesterol, that was reduced. Total cholesterol was reduced. Weight, which would therefore affect body mass index, and specifically weight due to fat mass, all were decreased. Plasma insulin was decreased. And then, not directly related to the metabolic syndrome, but of note, VO2 peak increased as well. VO2 peak is sometimes reported instead of VO2 max if we're not positive that it was a true maximal value, but it's referring to essentially the same phenomenon here. This figure looks pretty similar to the figure that I gave you in class. However, it is different. Look at the arrows here, and this figure taken from the Pulmifores article that you had to read for this week, it's depicting the direction of changes in specific factors related to atherosclerosis. So you'll see some are decreased and some are increased in response to exercise. So we see decreases in the cell adhesion molecules, decrease in C-reactive protein, increase in the endothelial progenitor cells over on the right, decreases in some of the interleukin factors here. And your text gets a lot more into, the text, I should say, the paper gets more into the level of evidence behind each of these. So look at this closely and read the text that goes with it in the article to have a good grip on this in terms of exactly how and why exercise is affecting specific factors related to atherosclerosis. Really nicely showed how we have a dual effect in terms of cytokines changing in response to exercise. We get decreases in pro-inflammatory cytokines and then increases in anti-inflammatory cytokines. So you can get more out of this by reading the text from the paper about it, but you can see that C-reactive protein, leptin, and resistin levels decreased, whereas adiponectin increased, and these are all positive changes. Graphs from the Balducci article, so make sure that you reread that closely to have a good understanding about how there are both increases in anti-inflammatory markers and decreases in pro-inflammatory markers in response to exercise training. Week. And just as a reminder in terms of how to read meta-analyses, the figure shown here reports the data from a lot of different studies. So each of these squares, the black squares, represents the results from one study with the mean value and then the 95% confidence interval. And you can see the legend at the bottom where if the point is to the left of the 0 line, it favors exercise. That means exercise improves blood pressure more significantly than a sedentary control. And you'll see basically almost every study is to the left. And then at the bottom where we have the large diamond, that shows the overall results of all of the studies together collectively indicates that exercise is favorable for lowering blood pressure. Now, importantly, These were the effects of exercise on ambulatory blood pressure. That's not the blood pressure when you're sitting down at one point in time, but it's representing your average blood pressure over the course of the whole day. So pretty important that we see that it affects blood pressure for the whole day, at least during the daytime, not so much during the nighttime, according to this study. Here's another paper looking at blood pressure. This was also done at Arizona State University. And this study was comparing the effect of one 30-minute bout of exercise, so pretty standard recommendation for exercise, compared to 3 10-minute bouts. And the primary outcome was looking at ambulatory blood pressure for 24 hours. Figure A here is comparing a control with 3 10-minute bouts. And in the morning, you can see it's pretty similar between the two, control and the 3 10-minute bouts of exercise. However, in the afternoon and in the evening, our open circles representing the 3 10-minute exercise bouts remained lower compared to the control condition. So this was showing that doing 3 10-minute bouts of exercise led to lower blood pressure in the afternoon and evening following afternoon and evening of the day with those types of exercise bouts interspersed. And then figure B, on the other hand, is comparing the effect of one 30-minute session with a sedentary control. And there were no significant differences at any time point between the control and the 30-minute exercise group for ambulatory blood pressure. Analysis looking at blood pressure. So here, this particular meta-analysis was interested in determining what about exercise most influences blood pressure responses. Is it volume? Is it intensity? Does that matter? And they included both people with normal blood pressure as well as people with high blood pressure. This was a pretty big meta-analysis. It included 44 randomized controlled trials, which covered 2,700 individuals. Wide age span, you can see how long the various studies lasted. Majority of them included exercise about 3 times per week, although it ranged between 1 and 7 days per week. Mostly walking, jogging, running, a little bit of cycling and swimming, and some other exercises, and the intensities ranged from 30% up to 87% of maximal exercise. Table, it's pooling all of the results together, so it's not differentiating by duration or by intensity. But overall, exercise elicited the following changes in blood pressure. Systolic reduced by about 3.4 millimeter mercury. Diastolic went down 2.4 millimeter mercury. Oxygen uptake went up, or VO2 max went up. Heart rate went down, and then body mass index went down as well. So all positive improvements here. Real take-home messages from this meta-analysis are: 1, exercise reduces blood pressure. For normotensive individuals, those who do not have high blood pressure, it led to a reduction of about 3 millimeters mercury in systolic blood pressure and 2 millimeter mercury in diastolic blood pressure. And that reduction was a lot bigger among people with hypertension. No convincing evidence that higher intensity is better. There were really no differences between exercise intensity at 40% and at 70% with respect to reducing blood pressure. Also, exercising 3 or 4 or 5 days per week between 30 and 60 minutes also led to similar effects on blood pressure. However, when we take this out farther and when we compare 3 days compared to 7 days per week, it appears that 7 days per week might be better for eliciting greater reductions in blood pressure. So conclusions here, along with another study we'll talk about in a moment, are really that exercise reduces blood pressure. Intensity is not that important, however. Turning from blood pressure now to lipids, this study by Krause and colleagues compared the effects of various amounts of exercise as well as different intensities of exercise on outcomes on our plasma lipoproteins. Groups from the study, there was a sedentary control group, then a low volume moderate intensity group who expended about 1,200 calories a week from their exercise, which was supposed to be the caloric equivalent of approximately 12 miles per week of walking, and just at 40 to 55% of their peak oxygen uptake. Then we had still low volume, but high intensity, so about the same calorie expenditure, so still 1,200 calories a week, but now at 65 to 80% of peak oxygen uptake. And then there was a high volume, high intensity group, so almost double the caloric expenditure, but same intensity, 65 to 80% of peak oxygen uptake. Now, the reason that there was no high volume, moderate intensity group is that would just take a lot of time to be able to get that same volume, but at the lower intensity. So here are the exercise groups. And here are the data from the study. Let's start with panel A, looking at the change in concentration of the small LDL cholesterol. So when we talk about LDL, usually people just refer to LDL collectively, but there are actually different size particles of LDL. So looking specifically at small LDL here. And on the left, the figure or the bar that increased there was showing the control group. So they got worse. And then we moved to the low amount of exercise at moderate intensity. And so some of that was prevented. And then continuing on, the low amount with high intensity, so further reduction in change. And then on the right here, we have the high amount and high intensity. So you can see that volume appears to be the most important factor here, because even keeping intensity the same, keeping the volume the same at the low amount, there's not a lot of difference between moderate and high intensity. But then when we go from low amount, high intensity, compare that to high amount, high intensity, there's a big change. And this is a positive change to have the reduction in the concentration of the small LDL cholesterol. You want less of the LDL. Coming over to panel B, looking at the concentration of LDL particles as a whole, so not just the small LDL. So still looking at concentration, and it was the same pattern of change as in panel A, where the high amount, high intensity had the most protective effect in terms of reducing the concentration of LDL. Now coming down to panel C, we're looking at the size of the LDL particles. And each of the exercise groups had a significant increase in the size, which is a positive adaptation here. But this was most pronounced as intensity increased and as volume increased as well. And then lastly, looking at intermediate density lipoprotein, IDL, we can see, same as in panel C, that there's a progressive effect. And the only one, though, that actually reached statistical significance was the high amount, high intensity intervention group. So take home from here would be that the high amount is really what would be driving the effects here. even more than the low amount, high intensity. The high amount, the volume is key. So the last slide was looking at LDL changes. This is showing changes with HDL, high density lipoprotein. What we want to increase, more is better here. Beginning with panel A, we can see it's the same order of the exercise interventions, going from the control on the left to low amount, moderate intensity, low amount, high intensity, and on the far right, high amount, high intensity. And really, really drastic change, perhaps even more so compared to LDL, in terms of the driving force increasing HDL would be volume of exercise more than intensity. Volume is key. In fact, it was the only one with a significant effect. All right, so here we have the summary from the study that's comparing the effect of amount and intensity on each of the variables. The way this is reported, let's just look at the top line, looking at concentration of small LDL particles. We can see the amount of exercise that most affected this was the high amount of exercise, followed by a low amount, followed by the control. So in terms of volume, the high amount was the best. And then one column over to the right, you can see high intensity had the most pronounced effect, followed by moderate intensity, followed by the control. And that's the way the data are presented for each of the variables. So we can see which amount of exercise was most helpful, and in every single one except for the size of VLDL particles, the high amount was the most important, the one that changed the variable the most. And then we can look at the right and look at the effective exercise intensity. And this was more mixed. It looks like for about half of the variables, high intensity had the most pronounced effect, whereas for the other half, moderate intensity had the most pronounced effect. But conclusively, with respect to volume, we can see the high amount was superior. Is a meta-analysis looking at the effect of exercise training on HDL specifically. Previous studies were looking at lipoproteins as a whole, but this one focused exclusively on HDL. And this figure shows the flow chart in terms of the number of studies they started with as potential options and how that got whittled down to about 25 studies that were included in the analysis. The studies that they included in the meta-analysis. The red line is representing 0 or no change in response to exercise. And you can see many of the studies do indicate the mean change was an increase, which is what we would want because we want higher levels of HDL. However, a lot of them have error bars that cross that 0 line, indicating that it might not be a significant difference. And if we come down here, there were a few studies that found a reduction in HDL. Overall, though, taking it down to the bottom diamond, we can see that all of the studies put together indicate, on average, an increase of about 2.5 units for HDL, milligrams per deciliter. So variability in response, it does appear that regular aerobic exercise modestly increases HDL. Volume here is probably the most important factor, not intensity, just like our previous study suggested as well. And then interestingly, the increases were more pronounced among subjects who had high levels of total cholesterol to begin with for some reason. This is the figure that we went over in class, or at least that I handed out in class. And I want to go over it again as a summary of everything that we've talked about thus far about exercise and the effect on atherosclerosis. So we'll work our way through the figure here. To begin with, we have the text here, but shear stress during exercise, that increase in the blood being pumped, is really what's driving the endothelial health improvements here. That increase in shear stress is leading to an increase in endothelial nitric oxide synthase, eNOS, which is the enzyme that's stimulating production of nitric oxide. And the increase in production of nitric oxide is what's increasing our ability to vasodilate. So that's a good thing. At the same time, this is also the increase in shear stress is decreasing the oxidation of the LDL that's already present in the blood. So you can see in the figure here, we have the little LDL particles, but it's a good thing if they're less likely to become oxidized, because then they're less likely for the macrophages to come in, engulf them, turn into foam cells. All right, moving on now, coming back here. In addition to less likely to become oxidized, exercise also lowers overall levels of total cholesterol and low-density lipoprotein. HDL levels go up as well, about 10 to 17%. So the meta-analysis that we looked at, where it was an increase of about 2.5 milligrams per deciliter on average, that still is important. It might sound like a small number, but that still is, that has clinical importance. And then triglycerides, another type of lipid in the blood, those tend to decrease in response to exercise. Now, next part here in the progression of atherosclerosis, VCAM, ICAM, those are different types of cellular adhesion molecules, and E-selectin as well. Those levels decrease in response to exercise. And this is beneficial because then it's less likely to call in the inflammatory response. So less monocytes will be coming in, less macrophages will be coming in, less macrophages to engulf the LDL that had become oxidized. Everything is reduced in terms of the inflammatory response. And some other things that decrease. MMPs are matrix metalloproteinases, and it's what they do, they kind of break down the plaque. So in some ways that could be beneficial, but when we're looking at an atherosclerotic plaque, if the MMPs are degrading the plaque, it makes it more likely for it to rupture, leading to the release of a blood clot. So in this case, the MMP action is not good. A decrease in levels of fibrinogen, that's the precursor to fibrin that you see up in the top right corner. And again, that's part of this plaque development, so it's good that we have a decrease in fibrinogen. And then another factor that decreases as well, PAI1, plasminogen activator, and I'm blanking on the I right now. But again, it's all part of the plaque development, and so for there to be lower levels, this is positive. It reduces likelihood for the plaque to be building. And big old summary here. Increases in levels of high-density lipoprotein decrease the plaque. Sometimes it's called the scavenger because it takes out some of the cholesterol that would otherwise be deposited. And this, therefore, decreases inflammation. We have lower blood pressure in response to exercise, and that decreases vascular injury. Exercise also leads to just overall lower levels of blood glucose at all times. And so because there's less glucose, then the vascular walls are less likely to become glycosylated. Again, an advantage there. And then the pro-inflammatory cytokines decrease. Here's a non-exhaustive list of some of the pro-inflammatory cytokines. And then the anti-inflammatory ones increase. So dual action in terms of the cytokines, decreasing the bad, increasing the good ones.